Hello everybody, I'm Dr. Alaa Mosbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. Let us try to answer some Osce in gynecology. Okay, look to this picture please and define what is seen in 1 and 2 in this picture. Look to this picture, this is 1 and this is 2. As you see, 1 is uterine mass, this is leiomyoma or fibroid or fibromyoma. Okay, so number 1 is leiomyoma. What about number 2? Number 2 showing hydrosalpinx. The tube is dilated and there is fimbrial phimosis, so this is hydrosalpinx. Okay? Okay. So number 1 is leiomyoma, number 2 is hydrosalpinx. Go to the next slide please. How to differentiate uterine mass from adnexal mass. This is a very important question in gynecology, how to differentiate uterine mass from adnexal mass. As you know, adnexal include the fallopian tubes, ovary, and the commonest mass in the adnexal is ovarian mass, ovarian cyst mostly. Also others like hydrosalpinx, biosalpinx, tubo-ovarian abscess, tumors, and the broad ligament mass. Okay, so I have many differential diagnoses. In uterine mass, I have also many differential diagnoses. On top of them is pregnancy, then leiomyoma, okay, adenomyosis, polyps, okay, endometrial carcinoma, uterine sarcoma, all these uterine mass. Okay, how to differentiate uterine mass from adnexal mass? This is a very important question, as I said. Let us try to differentiate from history, from abdominal examination, and from bimanual pelvic examination. Okay, from history, the age. Okay, from history, the age. The age of childbearing, as in leiomyoma, is a disease of childbearing age. So, and the leiomyoma is a very common lesion, benign tumor in the uterus. So, the childbearing age is with uterine mass, while the older age, like ovarian, malignant ovarian tumor, is with older age, as in advanced age. Okay, so of course uterine mass and adnexal mass, when I say age, childbearing age in leiomyoma is more common, so uterine mass is more commoner in childbearing age, while ovarian tumor malignancy occurs more in older age. But every one has an exception, of course, because I can see ovarian mass or tubal mass in childbearing age, but we are saying what is more common. Okay, but there is exception, of course. What about the complaint? When the patient complaining of vaginal bleeding or abnormal uterine bleeding, this is with uterine mass, more with uterine mass, not adnexal mass. Okay, so as regard the complaint also, this is from history, age and the complaint. What about abdominal examination? The position of the mass. If the mass in the midline, this is more with uterine mass. If the mass in lateral region, in one iliac region, this is adnexal mass. What else? What else in abdominal examination? If the mass is solid or hard, consistency, this is mostly uterine mass, as in leiomyoma. While if it is cystic, it is more with adnexal mass, because ovarian cyst is the commonest lesion in the ovary, more than solid. However, solid mass can be detected in the ovary, but cystic lesion is more common. Hydrosalpinx, the biosalpinx is cystic lesion, and so on. So, solid or hard mass is more with uterine mass, cystic is more with ovarian mass. However, there is exception, of course, as I said. What else in abdominal examination? There is test called finger below test. If I can insinuate my finger below the mass while I'm doing abdominal examination, is it uterine or ovarian? If I can insinuate my finger below the mass, it is ovarian. If I cannot insinuate my finger below the mass, this is uterine, because the mass, the uterine mass is a pelvic abdominal, so I cannot reach below the mass. But in ovarian mass becomes an abdominal organ when it is enlarged, I can insinuate my finger below the mass. This is called finger below test. So I can insinuate my finger below the mass in ovarian mass, but not uterine mass. So as you see in abdominal examination, we said the position of the mass midline with uterine, lateral with adnexal. Consistency hard or solid, consistency more with uterine, cystic more with adnexal. Finger below test, I can insinuate my finger below the mass in adnexal ovarian mass, but not in uterine mass. Okay? Okay. What about the bimanual examination? How to differentiate uterine mass from adnexal mass by bimanual examination? During bimanual examination, if I found this sulcus between the mass and the uterus, this is adnexal. So if there is sulcus between the mass and the uterus, this is adnexal mass. If there is no sulcus, as in uterine mass, this is uterine mass. As in leiomyoma, sorry, as in leiomyoma, this is uterine mass. So in case of uterine mass, there is no sulcus. But in adnexal mass, there is sulcus, or space or tunnel between the mass and the uterus. Of course, there are some exceptions. If there is ovarian malignancy infiltrating the uterine wall, there is no sulcus. If there is infection and adhesion to the uterine wall, there is no sulcus. So if the adnexal mass or ovarian cyst or tumor adherent to the wall of the uterus, I cannot find the sulcus. It's considered as a one mass. But this is the exception. So we want to know the rules first, then know some exception. So sulcus between the adnexal and the mass and the uterus, this is adnexal mass. No sulcus, this is uterine mass. What else in bimanual pelvic examination? If I tried to do mobility of the mass, the mobility will be transmitted to the cervix while I'm doing BV examination. This is uterine mass. But if I'm trying to move adnexal mass, the mobility, of course, will not be transmitted to the cervix. So, if the mobility of the mass transmitted to the cervix, this is uterine mass. If not, this is adnexal mass. By the way, because I forgot to say that, what about the movement of the mass by abdominal examination, side to side and up and down? Because I forgot to say it on abdominal examination. If the mass moving up and down and side to side, this is Adnexal. If the mass move side to side but not up and down, this is Uterine, of course. Okay? So, this test is done during abdominal examination, movement from side to side, up and down. Side to side only, but not up and down, this is Uterine. Side to side and up and down, positive, so this is Adnexal mass. Okay? On bimanual pelvic examination, if I try to move the mass from side to side like this mobility will be transmitted to the cervix if it is uterine mass. But if I try to move adnexal mass, the mobility will not transmit it to the cervix. This is another difference. So let us summarize what we said in this table as regard how to differentiate uterine mass from adnexal mass. This is the complete answer from history and examination. From age, uterine mass is more common at childbearing age, adnexal mass more common in older age, abnormal uterine bleeding more common with uterine mass, rare with adnexal lesion. Position of the mass usually central or midline, adnexal mass usually lateral. Mobility of the mass side to side only in uterine mass, but side to side and above and down in adnexal mass if it becomes abdominal. Transmission of the movement of the mass transmitted to the cervix present in uterine mass but not in adnexal mass. There is sulcus between the mass and the uterus in case of adnexal mass but not the uterine mass. Consistency mostly solid in uterine mass, cystic or solid in adnexal mass but more commonly cystic. This is the complete answer of how to differentiate clinically between uterine mass and adnexal mass. So let us go to next point, which is the differential diagnosis of uterine mass. Maybe benign leiomyoma, very common as I said before, affecting large number of women during the age of childbearing age, reaching up to 25%. Also leiomyoma variant, the mitotically active one, and the atypical leiomyoma, the uterine adenomyoma or diffuse adenomyosis, uterine sarcoma, uterine carcinosarcoma, endometrial carcinoma, metastatic neoplasm, endometrial polyp, endometrial hyperplasia, hematometria and biometria. When the uterus is filled with blood, it's called hematometria. When the uterus is filled with pus, it's called biometria. Pregnancy, don't forget pregnancy, please, and put it number one, because any woman in childbearing age with uterine mass, you should exclude first pregnancy. Don't forget this point because it is very important. Because if I asked you what is the commonest uterine, enlarged uterus, the commonest cause of enlarged uterus in childbearing age, you should answer pregnancy, of course. Don't forget it. Let us go to the next important point. What is the differential diagnosis of adnexal mass? Okay, let us divide it into groups. The first group is gynecologic benign lesion. The second group, gynecologic malignant lesion. The third group, non-gynecologic benign lesion. The fourth group, non-gynecologic malignant lesion. So, let us start with the gynecologic benign and malignant. Benign like functional cyst, corpus luteum cyst, follicular cyst, luteoma of pregnancy, also mature teratoma, ovarian torsion, serous and mucinous cystadenoma, polycystic ovary, cecal lutein cyst, ectopic pregnancy, endometrioma, hydrosalpinx, leiomyoma. What is leiomyoma? I said leiomyoma in the uterine mass, not adnexal, but here leiomyoma also can be broad ligament leiomyoma, or ovarian fibroma. Also, it affects the ovary, benign tumor of the ovary called ovarian fibroma, or leiomyoma of the broad ligament. tubo-ovarian abscess, all these gynecologic benign lesions. What about the gynecologic malignant lesions, like malignant ovarian tumor, like fallopian tube carcinoma? Okay, let us go to the non-gynecologic lesions, whether benign or malignant. Benign, appendicular abscess, appendicitis, bladder diverticulum, diverticular abscess, pelvic kidney, nerve sheath tumor, urethral diverticulum, peritoneal cyst. What about the non-gynecologic malignancy? GIT carcinoma, giving metastasis to the ovary, what is called the Krockenberg tumor, metastasis from breast, colon, retroperitoneal sarcomas. So this is the differential diagnosis of adnexal mass, and you should answer it like that. Gynecologic lesions, benign or malignant, or non-gynecologic lesion, benign and malignant. I hope it was clear enough. Thank you, everybody. This is my books published on Amazon, textbook of obstetrics, textbook of gynecology, contraception handbook, and the multiple choice question book. And this is my site on Amazon as an author, and this is my site on YouTube channel where you can find many updated lecture and quizzes. Also, this is another scientific site belong to me. Thank you, everybody. Hello, my dear. I'm Dr. Alaa Mosbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. Okay, we have an Osce in gynecology. Try to answer. Please look to this picture and identify this instrument. Of course, this is casco, non-fenestrated bivalve self-retaining metal vaginal speculum. 2 blades, handle, and screw. Okay? Okay. Another one, this is different. It is also bivalve metal self-retaining vaginal speculum, but there is some difference between this instrument and the previous one. This is called Graves. Graves, non-fenestrated self-retaining metal vaginal speculum. 2 blades, 2 screw, not 1 screw, 2 screw, and the handle. Okay? Here there is another screw connected between the lower plates and the handle to allow for better space during manipulation. So if you are doing procedure, needs instruments and needs a space, Graves is a better choice than Casco. So both of them nearly has the same indication, but for better exposure, you can use Graves. Okay? So the previous picture, please notice the difference. This is the Casco speculum, only 1 screw. The upper plate and the lower plate equal in size. Okay. What about Graves? Graves, the upper plate is shorter than the lower plate, as you see here. The upper plate is shorter. Also, it has 2 screws, not 1 screw as Casco. So Graves has 2 screws, and the upper plate is shorter than the lower plate. Okay, let us go to the next. What is the indication of this self-retaining metal vaginal speculum? Okay, it is used to expose the cervix, mainly the cervix, and the vaginal wall during examination, but mainly the cervix. Okay. Also, it allows the application of local instruments to the cervix, or obtaining swabs or smear swabs for infection, cotton-tipped swab, or cervical smear for screening for cervical carcinoma. Okay, so I need to use this self-retaining vaginal speculum to do this procedure. Also, it allows introduction of uterine sound, insertion of IUD, intrauterine device. Also, it's important to use this self-retaining vaginal speculum before hysterosalpingography. Also, when you are trying to take premenstrual endometrial biopsy or endometrial biopsy for abnormal uterine bleeding. Okay? So these are some indications for use of the metal self-retaining vaginal speculum, whatever Casco or Graves speculum, and now we know the difference between both. What is the advantage of this bivalve metal self-retaining vaginal speculum, Casco and Graves? Simple application without anesthesia. I don't need any anesthesia when I use speculum, self-retaining vaginal speculum, like Casco or Graves, okay? Being self-retaining is advantage because I need no assistance, okay? Because it is self-retaining. The availability of different sizes, small, medium, large, there is 3 or 4 sizes to accommodate different vaginal size, okay? So another advantage. What is the disadvantage? Maybe in some women they may feel little discomfort during insertion, especially in nullipop. It hides the anterior and the posterior vaginal walls by the plates. This is another disadvantage. Also, it doesn't offer complete protection of the vaginal walls during cauterization of the cervix. This is another disadvantage. Okay, go to the next, please. Identify this instrument in the picture. What is this instrument? This is SAMS vaginal speculum. SAMS vaginal speculum. Okay, what is the indication of SAMS vaginal speculum? For diagnosis and operative repair of vesico-vaginal fistula, because it gives me a better exposure to the anterior vaginal wall. Okay, I do retraction to the posterior vaginal wall using the SAMS speculum, so I can see anterior vaginal wall very well. Okay, so either diagnosis and operative repair of vesico-vaginal fistula can be achieved using SAMS speculum. Also, it can be used for diagnosis of pelvic organ prolapse, and also it can be used to insert a vaginal pad. Okay, this is the indication for SAMS speculum. Of course, I can use it in SAMS position and in other positions. In case of vesico-vaginal fistula diagnosis, I use SAMS speculum, and SAMS position is a better. Okay, what is the advantage of SAMS speculum? Gives me good exposure of anterior vaginal wall. Yeah. Provide space during vaginal surgery. Simple application without anesthesia. I don't need anesthesia while I'm using SAMS speculum for diagnostic reason. Simple application without anesthesia. The presence and availability of different sizes, small, medium, or large, to suit different vaginal size. What are the disadvantages of SAMS speculum? Assistance is required, especially when it is used to expose the cervix or during surgical procedures, because it is not self-retaining speculum. So, being not self-retaining speculum, so it is a disadvantage. Okay? In the presence of large cystocele, exposure of the cervix is often difficult when you are using SAMS speculum. Okay? Let us go to the next. Identify this instrument in the picture. What is this? This is Auvard self-retaining vaginal speculum. Plate, handle, weight, attach it to weight to keep it in place. this blade retract the posterior vaginal wall, and this groove allow for passage of blood or discharge or washing through it downward through this groove. Okay. What is the indication of Auvard speculum? It can be used in most gynecologic operation as it gives good exposure of anterior vaginal wall and the cervix during operation. Like what? Like DNC, like classical repair for prolapse, like anterior vaginal, like anterior repair in case of cystocele, like vaginal hysterectomy. Also, it is used also in surgical evacuation of abortion. What are the advantages of Auvard speculum? It is self-retaining by its attached weight. It gives good exposure of the anterior vaginal wall and the cervix during operation. This is another advantage. What are the disadvantages? It may tear, bruise, or overstretch the soft tissue of the perineum and the posterior vaginal wall because of this heavy weight. Okay? Attach it to it. It is difficult to use in nullipara. It hides the posterior vaginal wall. Look to the next. Identify the instrument in this picture. This is SIMS uterine sound, graded in centimeter. Okay? Okay. What is the indication for using uterine sound? Period to procedure to determine the direction of the uterus and the length of the uterus. What are the operations? You may use uterine sounding before the NC, before insertion of an IUD, for example, to avoid perforation. To differentiate uterine inversion from submucous fibroid, we need uterine sounding. Okay? If there is uterine inversion, uterine sound cannot go through the cavity because the uterus is inverted. While in submucous fibroid, the sound can pass to the uterine cavity. Also, to differentiate between uterine polyp and cervical polyp. In case of uterine polyp, the sound can go around it, while in cervical polyp, cannot go around it. It determines the relation of the uterus to any pelvic mass. To know and differentiate the uterine mass from adnexal mass and so on. Also, to diagnose cervical stenosis. These are the indication of uterine sound. What are the complications of uterine sound? Disturbance of an undiagnosed pregnancy, perforation of the cervix or body of the uterus, ascending infection. All these are complications of uterine sound. What are the contraindications? Suspicion of pregnancy. If you are suspecting pregnancy, never to do sound, uterine sound, because you will disturb this pregnancy. Okay, so contraindication if there is suspicion of pregnancy. Also, in case of soft uterus, like malignancy, infection, or molar pregnancy, because you can perforate the uterus easily in this soft uterus. Go to the next, please. Look to this picture. What is this shown in the picture? This is Hegar uterine dilator. Hegar uterine dilator. What are the indications for using Hegar dilators? Maybe diagnostic, therapeutic, or as a step in the course of other operations. Diagnostic for cervical incompetence. If Hegar 8 passed easily, this indicating cervical incompetence. Also to diagnose intrauterine lesions and septum. superior to hysterosalpingography in certain cases with narrow cervical os. You may need Hegar dilator to dilate the cervix. To diagnose spasmodic dysmenorrhea. Also, therapeutic indications like cervical stenosis, like dysmenorrhea, like drainage of hematometra or biometra, like cervical abortion. Also, as a step in the course of other operation like D&C or evacuation, like Vaginal operation and the tracheography or amputation of the cervix, like removal of fibroid or an endometrial polyp, before the insertion of certain IUD, also before removal of certain IUD, you may need Hegar dilator in some cases, okay? In some cases. What are the complications of Hegar dilators? Cervical incompetence and the habitual abortion is a very important complication of uterine Hegar dilator. Cervical incompetence and the habitual abortion, perforation of the cervix or body of the uterus, ascending infection like cervicitis, endometritis, salpingitis, laceration of the cervix, anesthetic complication because Hegar dilator should be used under anesthesia. Never to use it without anesthesia because this may cause vagal shock. Okay, vagal shock. Contraindication for using Hegar dilator, active genital infection, not to spread the infection. Also, normally pregnant uterus is contraindicated to use Hegar dilator. Okay, this is our ASCII today. I hope it is helpful for you. This is my box published on Amazon. You can go to find it. Textbook of Obstetrics, textbook Gynecology, Contraception Handbook, Multiple Choice Question Book, and the Medical Disorder in Pregnancy and the Gynecologic Oncology book. This is my site on Amazon as an author. This is my site on YouTube where you can find many other quizzes and lectures and OB guide. This is my scientific site on Blogspot also. Wishing you all the best, everybody. Thank you. Hello, my dear. I'm Dr. Alaa Mosbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. Let us try to answer some ASCII in gynecology. Okay, the first station here, look to this picture and identify A, B, and C. Okay, as you see in this picture, A is cytobrush. Cytobrush used for taking cervical smear as a screening program for cervical carcinoma. B, Ayer's spatula, also used for cervical smear for screening for cervical carcinoma. So A is cytobrush, B, Ayer's spatula. C is the procedure of cervical smear in screening program. We use cytobrush, Ayer's spatula to do cervical smearing. Okay. The procedure is done post-menstrual. The patient shouldn't be menstruating, shouldn't take any antibiotic or antifungal, local or systemic, in the previous 3 days. No vaginal douches 3 days ago. No intercourse, so not to affect the result of cervical smear. Okay. We use either cytobrush or Ayer's spatula. After inserting a clean speculum without antiseptic or any other solutions, so not to affect the smear, or gel. After insertion of gastric speculum or Graves speculum, self-retaining speculum, exposure of the external os is good. Then insert the Ayers spatula till the external os, then rotate 360 degree, then another 360 degree, then remove it without touching anything. Then spread the cell on a slide and spray it with a fixator, then send to the lab for PAP test, Papanicular test, or PAP smear test. Okay? Why we are doing this? To diagnose the pre-invasive lesion like CIN 1, 2, or 3. CIN 1 is low risk, CIN 2 and 3 higher risk. CIN means cervical intraepithelial neoplasia. Okay? When to start this screening program? In some countries it started at the age of 21. Then repeated every 3 years till the age of 29. Then from the age of 30 up to the age of 65, we either do PAP test every 3 years or human papilloma virus test every 5 years, or human papilloma virus test and the PAP test, we call it co-test, done with each other, human papilloma virus and PAP smear, co-test every 5 years. Till the age of what? Till the age of 65, then we stop doing screening program. So the screening program start at the age of 21 and end at the age of 65 years old. Okay? And this screening program is important, as I said, to diagnose the pre-invasive lesion CIN 1, 2, 3 and managed properly, so not to be converted to invasive cancer. Also diagnose the early cases of invasive cancer, so it can be managed early. Okay? So this is one of the most important screening program done in every part all over the world. Okay? Let us go to the next. Identify A and B. Look at this picture and identify A and B. A, cotton-tipped swab. B, cervical swab for infection. For vaginal discharge or infection related to sexually transmitted diseases, for example, like gonorrhea, we can do high vaginal swab or swab from the cervix, from external os. How to do it? Also avoid use of antiseptic or antibiotic. Use clean self-retaining vaginal speculum. Insert it until exposure of the external os. Remove the cotton-tipped swab from the sterile bottle like this one. Insert it inside the vagina till reaching the external os. Then rotate 360 degree and another 360 degree. Then remove it without touching anything and insert it inside the clean tube and close it and send it for lab for evaluation of this organism and for culture and sensitivity test. So this is high cervical swab or high vaginal swab for infection in case of vaginitis, cervicitis, especially in cases suspected to have sexually transmitted disease or other infections. Okay, this is as regard this station. I hope it is clear enough. What is the complication of sexually transmitted disease like gonorrhea, chlamydia, and so on? Complication, one of the most important complications is salpingitis. Salpingitis can cause tubal block and can be cause for infertility, can damage the fallopian tubes, especially if it is bilateral, it can cause permanent obstruction of the both fallopian tubes if not managed properly and early. So when we diagnose any sexually transmitted disease, it should be managed early and adequately with the proper antibiotic. Okay? Complication may include infertility, as I said, so it is important, especially in young lady, to manage any sexually transmitted disease properly to avoid affection or her fertility in the future. Okay? What is next? Please look to this picture and identify A, B, C, and D. Look to picture A. This is bicornate uterus, bicornate unicollis uterus, bicornate uterus. Two cornea here. This is one of the anomalies of the uterus due to the defect in the development of Mullerian ducts. What about B? B is uterine didelphys. Each Mullerian duct developed separately. So you will find two uterus, two cervix, two vagina. This is called uterus didelphys, uterine didelphys. Another anomaly for development of Mullerian ducts. Okay, C. What about C? C here, septate uterus. As you see, the cavity of the uterus is divided into two compartments with septum in the middle. Okay, so this is called septate uterus. This also occurs due to abnormality in the development of Mullerian ducts. Mullerian ducts, we have two Mullerian ducts. When they fuse with each other, the separation at the middle must be resolved or removed or disappear. If persistent, leads to septate uterus. Okay. D is a unicornate uterus. As you see, there is one cornea, unicornate uterus, and the rudimentary horn on the other side. So this is unicornate uterus. Again, A, bicornate uterus, B, uterine didelphys, C, septate uterus, D, unicornate uterus. What are the complications of uterine anomalies? Maybe fertility, maybe miscarriage, preterm labor, heavy menstruation, abnormal uterine bleeding. All these are complications that may happen with uterine anomalies. Okay, this is the end of our Osce station today. I hope it is clear enough. You can find more Osce through my site on YouTube. I'll put it in a comment. This link related to my YouTube channel. The other link here in red related to Amazon, where you can find my books, textbook of obstetrics, textbook gynecology, contraception handbook, multiple choice question book, medical disorder in pregnancy, and the gynecologic oncology book. I'll put it in another comment. Wishing you all the best, everybody. Thank you. Hello, my dear. I'm Dr. Alaa Mosbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. Let us try to answer some Osce in gynecology, and this is part 6. You can see other parts before, but today we have some new Osce. Okay, let us start with the first. Identify from this picture PALM-COEIN classification of abnormal uterine bleeding. As we all know, PALM-COEIN classification, including the commonest causes of abnormal uterine bleeding. So, B for what? B for polyp, A for adenomyosis, L for leiomyoma, M for malignancy or endometrial hyperplasia. And this is one of the structural causes of abnormal uterine bleeding. What about the non-structural causes? In the word COEIN, C for coagulation dysfunction, O for ovulatory dysfunction, this is the ovary, ovulatory dysfunction, E for endometrium causes, I for iatrogenic causes like IUD insertion, N non-identified causes. So this is the PALM-COEIN classification as you see in the picture. When I ask you write it, so you should tell me this abbreviation denoting what. Okay, as you see in the picture, this is a polyp, this is adenomyosis, this is a leiomyoma, this is a malignancy. Okay, here is the coagulation dysfunction, here is the ovulatory dysfunction, here is the endometrial causes, arteriovenous malformation or inflammatory, and so on. I for iatrogenic as an ID here, N non-specific, and some or non-identified. Some put the scar, deficient scar after cesarean in non-identified causes, by the way. Okay? Okay. This is the first station. Let us go to the next. Look to this picture, please. Name the procedure. This is hysteroscopy. Identify A and B. A is intracavitary leiomyoma or fibroid. What is the type of A according to FIGO? Which type of fibroid? This one, the intracavitary one. This one with pedicle is called type 0 according to FIGO. So this is leiomyoma, and the answer, what is the type of A according to FIGO? This is type 0. I didn't say letter B denoting what? This is the uterine cavity, the endometrium, the normal endometrium or uterine cavity. So the pathology in A is leiomyoma, and the B the uterine cavity and the endometrium. Okay, with no other pathology. And the pathology here is type 0 leiomyoma. What is the common presentation and the ideal treatment for this case? The patient commonly complain of heavy menstrual bleeding, or the old name menorrhagia. Heavy menstrual bleeding or menorrhagia. Also, she may complain of colic, uterine pain. Okay. What is the ideal treatment for this condition? So long as it is a single intracavitary type 0 leiomyoma, 4 centimeter or less, so hysteroscopic resection of this leiomyoma is the best line of treatment. Hysteroscopic resection of leiomyoma. Okay? Let us go to the next station. During gynecologic examination, the following in the picture was found. Identify A and the best line of treatment. During the speculum examination, you found the portion of the cervix and this lesion. So A denoting cervical polyp, mostly mucus polyp. This is a large polyp and this is a small polyp. So two polyps here, large and the small polyps. Okay. What is the best line of treatment is to do surgical polypectomy. If it is suggested to be mucus polyp with a thin pedicle, you can use ring forceps and twisting until avulsion of the polyp is done and send for histopathological evaluation. Okay? What is the presentation of such a condition? The patient may complain of spotting, vaginal discharge, irregular bleeding, or post-coital bleeding. Okay? Okay, look to this picture, please. Identify the difference between A and B. A and B. A, there is septate uterus here. B is a normal uterus and genital organ. So, the abnormality in A is septate uterus. How to diagnose A? How to diagnose septate uterus? By visualization directly via hysteroscopy or by hysterosalpingogram. Okay. What is the best treatment of uterine septum in A? Hysteroscopic metroplasty or hysteroscopic resection of uterine septum is the best line of treatment. However, if asymptomatic and no complications, you may do just follow-up for the patient. But if the patient at risk of recurrent miscarriage or preterm labor, so hysteroscopic resection of the septum, what's called metroplasty, can be done via hysteroscopy easily. Okay? This is the best line of treatment if it is needed. Go to the next, please. During gynecologic examination, the following in the picture was found. As you see in this picture, identify A, B, and C. A is the portion of the cervix. B is the vaginal wall. C is ectropion or erosion. The old name called erosion is now not used anymore. Ectopy or ectropion replacing cervical erosion. Okay. What is the best treatment for C? Okay, you should know that cervical erosion or ectropion can occur physiologically during pregnancy, during adolescence, in a woman taking combined hormonal oral contraceptive or gestogen like medroxyprogesterone acetate. So hormonal effect of oral pills or injectable, or hormonal effect of pregnancy or adolescent phase cervical ectopion or ectropion can happen. Okay, so if it is asymptomatic, it needs no treatment. But if the patient is symptomatic, if the cause is hormonal pills, try to stop this method of contraception and replace it by another one, non-hormonal. Okay, but you should do a differential diagnosis for cervical ectropion and exclude CIN and infection by using exclude CIN by doing pap smear during screening program, colposcopy. Okay. Also, you may need to exclude infection like chlamydia and gonorrhea by nucleic acid amplification test. Okay. The patient of cervical ectropion may complain of vaginal discharge, post-coital bleeding, interministerial spotting, back pain, dyspareunia. So this symptomatic woman is the ideal who needs the treatment. So what is the treatment? Cauterization by dithermy electrocauterization, or cryotherapy, or laser therapy for this ectropion to replace this columnar glandular tissue by squamous epithelium. So damage of this one to replace it with squamous epithelium. Also, we can use polydeoxyribonucleotide like Albucil vaginal suppository as a treatment of cervical ectropion. So I can use chemical medical treatment, silver nitrate, polydeoxyribonucleotide, vaginal suppository like Albucil. You can use electrocauterization with dithermy. You can use cryotherapy. You can use laser therapy using carbon dioxide. So laser therapy or electrocauterization or cryotherapy or medical treatment, all of these are lines of treatment of cervical ectropion if the patient is symptomatic and after you exclude the infection with chlamydia and gonorrhea and the CIN by cervical intraepithelial neoplasia by doing pap smear and colposcopy. This is the end of this OSCE. I hope it was helpful for you. This is my site on Amazon where you can find my books. I put it in a comment. This is my site on YouTube where you can find many other OSCE stations, also lectures about obstetrics and gynecology and the family planning. So you can find it. I'll write my site in a comment on this video. Thank you, everybody. Wishing you all the best.